सर ड्राफ्ट इंटरेक्शन को बचाते रहोगे, अगर ब्लड शुगर ही 400 होगी तो इंटरेक्शन क्या करेगा? So basically, I tell you, 20 years back I saw a cartoon in Times of India where an environmentalist went to a poor person who was cutting the wood and burning कि भैया पेड़ काट रहे हो, जला रहे हो, अगली जनरेशन खत्म हो जाएगी।
So
वो कहता अगर मैं पेड़ नहीं जलाऊंगा,
I understand this is an individual choice. We all agree to that.
Yes.
So last question from our chair, maybe.
As an extension of our discussion, so one patient who is on already, obviously type 2 diabetes mellitus, under control, and he is getting host of drugs for management of comorbidities and complications, including sulfonylureas for hyperglycemia management and also statin. And he or she developed tuberculosis, and after starting anti-tuberculosis, patients' liver enzymes now become elevated 2.5 to 3 times of the upper limit. And how would you like to modify the therapy for both these conditions?
You can't stop anti-tuberculosis therapy. Just stop the pioglitazone, for instance. Don't give it if he is taking pioglitazone. Give only sulfonylureas, insulin, which is used in hepatic failure, and monitor the hepatic function. You can't stop the TB.
Sulfonylurea could be continued in this condition, sir?
Sulfonylurea does not affect the liver that much.
I don't know. I would continue sulfonylurea.
So I just one line question. Do you have any data on MDR TB in diabetes?
No. We excluded MDR TB in this cohort.
Any data you know of, maybe?
No.
So is this
ask
high?
Only Zarir Udwadia.
Okay.
He is now a part of Report India, Hinduja Hospital,
Thank you.
Mumbai.
So we end our session here. Thank you very much, and thank you, Dr. Vijay Viswanathan, for your nice presentation. Over to the organizers now.
Talk, and I think we are looking forward to some exciting data. And now we are going to the last session of the day, the recent advances. I'll call on chair Dr. Arvind Arya, Dr. Bhagirath Solanki, and Dr. Alok Modi.
May I request our first speaker, Professor Soumitra Ghosh, and he would going to be speaking on novel pharmacological treatment for obesity and diabetes. Dr. Ghosh, all yours.
Respected chairpersons, my teachers, seniors, colleagues and junior friends, I'm thankful to my friend Dr. Patni for giving me this opportunity to talk on this forum on a very important topic, this novel pharmacological treatments for obesity and diabetes. It is an important aspect because there is a good link between this adiposopathy and this diabetes in different ways, which promotes insulin resistance and beta cell decompensation, and the incidence and prevalence of both these conditions go hand in hand in the same manner in these last decades. And we all know that this greater risk of developing diabetes with higher BMI is there because it is the ectopic fat in these organs which is causing this insulin resistance, beta cell dysfunction, and all the complications related to diabetes, the hypertension, dyslipidemia, fatty liver, inflammatory state, cardiovascular disease, kidney disease, everything. So this diabetes care management program gives this importance to weight management and the obesity care for the prevention and treatment of the type 2 diabetes mellitus. It is far more important, and it is such important that for every counter this weight management should be there, and it should be recorded in the patient's document, and at least 5% weight loss should be prescribed, and it should be an intense in the first 6 months. And while choosing glucose lowering medications, we consider these options of these molecules. We all know that GLP-1 receptor agonists, SGLT2 inhibitor, metformin, pramlintide, they cause weight loss, while weight neutral are these DPP-4 inhibitors, alpha glucosidase inhibitors, while insulin, sulfonylureas, meglitide, TZDs can cause weight gain. So it has become very important to note that this diabetes management has become more adipose-centric. So there has been a shift of framework from the primary focus on hyperglycemia to sustained weight loss as a primary treatment goal. And that is very important. And that's why this weight management is very important for these, 5 to 10%, 10 to 15%, 15 to, because for different outcomes, weight management is a very important thing, and more than 20% weight loss causes this heart failure, advanced type 2 remission, postural instability, etc. So much of improvement. So overview of the currently available anti-obesity pharmacotherapy, it actually targets this appetite, this orlistat, this phentermine topiramate, bupropion, this liraglutide, and etc. Only orlistat is there in India now, but the efficacy of the anti-obesity drugs is not very remarkable because they cannot do much of things. They have lot adverse effects of the currently anti-obesity drugs. This pharmacological treatment of obesity is far from satisfactory. Many of the drugs have been withdrawn from the market, and we have failed miserably because after some weight loss, the weight regain is always there. So because they depended on the appetite regulation. And as the hedonic appetite overpowers and overdrives the homeostatic appetite, they are all bound to fail. So these earlier anti-obesity medications just based on this control of the hypothalamus, now there has been a shift to this gut. This insulin secretion, glucagon secretion, etc. So lesson from the success of this metabolic surgery is targeting the obesity and the diabetes management is to come to these intestinal secretions, the GLP-1, PYY, etc., which goes high after this metabolic surgery. So after this success of this surgery, we have learned that drug therapy should target more than one pathways in the GI tract, the cocktail of GLP-1, oxyntomodulin, etc., and the different combinations to mimic the medical gastric bypass. Oxyntomodulin in 2005 report caused some subcutaneous injections, weight loss, and in 2015 liraglutide came and shone important light into these things, and then on the gut has become the novel target of treatment for obesity and diabetes together by modulation of the gut peptide, gut microbiota, and the flow dynamics of the bile. We all know that GLP has a multifarious actions on the liver, intestine, brain, muscles, pancreas, etc. And this GLP-1 having effect on the multiple systems, it takes care of these multiple pathophysiologic basis of diabetes together. And that's why in diabetes management, these are the mainstay molecules, including this weight management, this appetite regulation and weight loss. These are important things. So they are working together, and liraglutide after use in 56 weeks that can cause 5.8% weight loss, which is, and at the same time HbA1c is reduced significantly. But this amount of weight loss, this 5%, 10%, 15%, 20% is not possible with this. And this first generation concept, the second generation, the third phase for higher efficacy has come. The exenatide, liraglutide, dulaglutide, lixacenacide, they are the first generation. Now the second generation has come, the injectile semaglutide, oral semaglutide, and in the third phase trial, the oral semaglutide in the higher dose, orforglipron, danuglipron, these are the new things. So what is the second generation obesity medications which has important aspect in the diabetes management? They are considerably safe, they are efficacious, and in 10% weight loss they can cause in majority of the patients, and 15% or more weight loss in more than 50% of the patient, which is sustained. And it has been shown that the semaglutide has some impact, and it is a second generation one, and 9.6% weight loss can be caused in the injectile form to 2.4 milligram per week, and it can cause after 6 to 8 weeks, and it is superior and clinically meaningful decrease in the body weight along with this diabetes control. So oral drug and this injectile in the 2.4 milligram in the name of Wegovy has been approved by the US FDA recently. And you can see that the diabetes control and the weight management both are quite satisfactory with the oral sema as well as the injectile sema, and their cardiovascular outcomes in diabetes and without diabetes, they are quite acceptable. So they are safe, they are efficacious, and they can cause almost 10% in majority of the patients. But combination of these GLP-1 based therapies, they are the greater marvels. So what are these combinations? Different things. The glucagon, amylin, PYY, GLP-1, GIP. So different combinations, the dual combination, triple combinations, or these dual creatines of different types of combinations are giving a greater marvel result, because mainstay will be the GLP-1 receptor agonist. It is the backbone of all novel pharmaceutical therapies. while it is combined with GIP or triple with GIP glucagon or with amylin or with PYY, it is giving a good result. So all second level molecules, second generation molecules are different combinations, including some monoclonal antibodies like bimagrumab, and different combinations are coming into the market, either they are in the pipeline or there. This twin creatine, the tirzepatide, has been approved in just last year, 2013 November only, and they have multiple actions, and basically with these multiple actions they are causing important physiological combinations, stimulating insulin secretion, the additive effect on this insulin secretion, and this greater weight and the HbA1c reduction with this combination. It is approved in November, and this impressive HbA1c and the weight reduction, 11.9% or 12.4% body weight with 10 or 15 milligram per week injection over 6 to 18 months. Now this non-peptide GLP-1 is also coming. These are oral drugs. These orforglipron and danuglipron, they are very important. They have a prolonged half-life. As being the non-peptide, they are given once daily. They are more powerful, they are more stronger, and they can cause 2.1% reduction in the HbA1c and with good amount of weight loss. So with obesity, they are very, they have successfully been proved in the, and they are in the phase 3 trial now. You can see the HbA1c reduction, body weight reduction, both are quite satisfactory with 24 milligram or 36 milligram per day daily doses. As it is a non-peptide, this strict fasting is not required like this oral sema, strict cold chain is not required, and they are the welcome addition in the basket of the GLP-1. And this danuglipron is also in the pipeline, and these are the areas where we can have these new drugs, because it is not possible to remember all these researches which are going on, but we can at least identify which areas are having the maximum potential to have a novel pharmaceutical agents which can control diabetes as well as obesity. This twin creatine cagrilintide and the semaglutide combination, because we all know this amylin is very important molecule here, and it is co-secreted with insulin. Pramlintide is already approved. It is a fast synthetic amylin analog, but cagrilintide is the newer long-acting once-weekly amylin analog. So this cagri-sema combination is actually doing a marvelous things. It is in the phase 3 trial. 2.4 milligram once weekly injections that can cause 8 to 17% weight loss with the HbA1c reduction of 2.2%. So this combination is long-lasting weight loss that can sustain and that can be efficacious also. So this pilot study of this cagri-sema 2.4 milligram is well tolerated and acceptable safety profile. Now this retatrutide, this combining 3 molecules together. So the previous one was a dual agonist, now it is the triagonist. With this triple combination, all these diabetogenic effect of glucagon is actually being buffered with GIP and the GLP, and it is giving a good result because that can combine all the functions of almost all organs together, and it is in the phase 2 trial now, this triple hormone receptor agonist retatrutide. And this survodutide, that is a combination with the glucagon receptor. It is a dual agonist, and that is the once weekly that can cause 6 to 8% weight loss with HbA1c reduction of 1.9%. It is in the phase 2 trial, and lot many molecules. Not only the survodutide, it is mazdutide, it is the pemvidutide, it is the efinopegdutide. These are the molecules. So they can cause significant, they have a good safety as well as this efficacy. So it is also being used for this metabolically dysfunction associated steatohepatitis. So because it can take out this organ fat also. So better diabetes control with the weight loss can be caused with a combination with the basal insulins, GLP-1. These combinations can be degludec and this liraglutide combinations once daily. It can be glargine with lixisenatide once daily, or it can be icodec with semaglutide once weekly. So advantage of both prandial and the glucose control with good amount of weight loss together. So other good areas are the gut microbiota alteration, because all know that the gut microbiota is a virtual organ, and all these gut microbiota changed in the diabetic and the obese persons, and this body phenotype can be transmitted by this gut microbiota, and following metabolic surgery they are all altered, and it is being used in different other conditions. The new era of treatment of this obesity and the diabetes is coming with this gut microbiota transplant. And this changing in the dynamics of the bile, this is very important area. With these operations which causes the distal, flow of the bile, they can cause a distinct change in the PYY, GLP-1, and these effects are Farsenoid X receptors, FGF19, TGR5. They can modulate the gut microbiota, incretins, everything, and that can good result in the diabetes control as well as the weight control. In several studies, it has been shown when the bile is actually delivered in the distal part, that can cause significant change in the GLP-1 level and the fasting insulin level. Now this set melatonin, that is a melanocortin pathway, that is a personalized weight management in select situations where this melanocortin pathway is involved, and it is being studied whether that can be transmitted or transformed into the conditions where the other obese and the diabetic persons are suffering. Drugs in advanced stages of development are bimagrumab, PYY, ghrelin antagonist, leptin, B3 agonist, etc. These are the molecules, that's the areas where the researches are going on. These are just the areas where we can have the potential drug formulation in the next few decades. Bimagrumab is a monoclonal antibody, and it is in the phase 2 in the obesity and the diabetes molecules, and marked reduction in the fat mass, but that can increase the lean mass, because all other things which decreases the body weight, they can decrease the muscle mass also. But this monoclonal antibody can increase the muscle mass, at the same time that can decrease the fat mass, which is beneficial. Other novel obesity pharmacotherapy which has good amount of impact on this diabetes control is the PYY, ghrelin receptor inhibition, leptin analog, metrelleptin, beta-3 agonist, etc. But these major areas of research are going on in the adipose tissue targeted therapy. Everybody will accept that the lifestyle modification, what we actually practice in every such situation, it is actually a adipose tissue targeted therapy. By lifestyle modification, we try to decrease the fat mass. And by these fat mass changes, we can change this insulin resistance by this white adipose tissue expansion. That can protect from the metabolic dysfunction like obesity and the diabetes. Just by changing this adipokine-based therapy, BAT activation, white adipose tissue browning, modulation of the PPAR signaling, etc. And lots of molecules are under development. And this leptin, FGF21 analogs, adiponectin, etc., white adipose tissue beiging, and mitochondrial uncouplers, beta-1 adrenergic receptor agonists, all have this PPAR signaling, etc. These TNF inhibitors, many drugs are coming which act directly on the adipose tissue, and that can change. Promoting healthy adipocyte differentiation, which promotes subcutaneous adipogenesis, promote brown adipogenesis, and prevent adipose inflammation, hypoxia, and fibrosis. If this can be done, that can have this effect, combined effect on the body weight management as well as the blood sugar management. Because PPAR gamma actually causes this adipocyte differentiation, and that is the way it can increase the body weight, but by new cell formation that controls the blood sugar level. So increasing the brown fat by various ways. And irisin is a molecule which is actually a betokine, the brown adipose tissue kines, and these skeletal muscles which are exercising, that can actually give rise to these exerkines. And if this exercise induced irisin can be injected into the unhealthy persons, that can cause good amount of beneficial effect on the body weight as well as the diabetes control. So days are coming when all these good doctors with lot of obese and the diabetes profile, they can be benefited by the persons who are exercising, like Michael Phelps and the Usain Bolt, because they are producing lot many irisin there, and if their nature exercising pill can be injected into these ideal doctors, they can be benefited in this field. So epigenetic modulation and the other emerging therapeutics in the leptin sensitizer, amylin calcitonin dual agonist targeting ghrelin pathway, mitochondrial uncoupler, etc. So to conclude, obesity and the type 2 diabetes are closely linked. Addressing adiposity is an important target for diabetes management, and it is an important turning point or the gut, adipose tissue, skeletal muscles are becoming the alternatives to metabolic surgery, function and manipulation of the gut peptide, gut microbiota, novel agents to decrease adiposity and improve the lean mass in the pipeline, and we can look forward to these days, coming years with the renewed hope. So the novel pharmaceutical therapies for the obesity and diabetes will come, because there is the best amount of researches are going on in this field across the globe in all good institutes. Thank you very much for your patient hearing.
Thank you, sir. You've done a fantastic research. You have covered all the molecules in the planet extensively, very nicely. Congratulations for doing a phenomenal research. And what I could gather, the retatrutide thing I had reviewed for my presentation, the current generation of medicines which is being researched, there's a paradigm shift. They're focusing more on adiposity rather than sugar. And I think the audience may not like it. They were all stalwart sitting here. But I think the days are not far when we would be lean and thin with good muscle mass thanks to these medicines. And we would be eating pizzas and burgers every day with nothing going wrong. Just a comment to be taken in a good intention, in the sense that these molecules are coming out to be so fantastic. Retatrutide, what I read was, it reduces your fat mass by 93% within a matter of, and phase 2 trial were actually stopped by Eli Lilly because the results were so fantastic. So sir, excellent presentations, very nicely covered. And this is something which I think should be carried on for 2 weeks symposium. So any comment from the audience?
It is going to be approved soon because it is in the fast track, in the US FDA situation.
Panda sir would like to say something.
Actually, the focus is shifting to diabetes and obesity.
Yes, sir.
As you told.
Absolutely. Weight management is the priority.
Yeah.
And that's why in these chapters in 2016, you will see the weight management chapter comes before these pharmaceutical agents.
Especially type 2 diabetes, the pathophysiology is so closely related to obesity. Now, focusing diabetes and obesity management will be together. And as rightly you have pointed out, the GLP, GIP and the glucagon combinations, and along with the SGLT2 and metformin, the lifestyle, the molecules revolving around the GLP will come into picture, and they'll take over the future.
That is the game changer, because the thought process was actually stuck with the hypothalamus. Yeah. Now we have shifted to the GI tract.
Yeah.
So in fact, I wanted to make one comment. Now, as in more and more guidelines for diabetes are coming out, the current guidelines are not taking metformin as the first drug. They're taking GLP and SGLT2 as the first drug. I think in the coming days...
Next talk is regarding that.
In the coming days, probably we'll have exclusively obesity guidelines. And just as today we are not writing only metformin or SU, we are writing a multiple combination on day one to give proper treatment for organ care. I think I may not be wrong, I may be wrong. Maybe 5 years from now we'll be meeting and we'll have an official guideline managing obesity with A, B, C and D drugs, not a drug. In obesity and diabetes, sulfonylurea metformin would probably be the story of the past, because these drugs will take care of diabetes first and sugar control as a corollary or as a consequence of that.
Like we discussed today, people with atherosclerotic cardiovascular disease, people with diabetic kidney disease, similarly there will be a category, people with high BMI or obesity.
Obesity with kidney disease, obesity. Yeah. And what I was trying to say is, 5 years from now, maybe we would have official guidelines for management of obesity, not diabetes. It will be a different branch altogether.
We need disease modifying drugs, not only these blood sugar decreasing drugs. Thank you.
So, sir, thank you very much. It was an excellent talk. And may we have the honor of inviting the next speaker for today. And that is a very interesting topic, and I'm sure we will not go without, this is something which will keep us glued to our seats. This is challenges of applying great findings in complex diabetes management. It's a very tough topic, and obviously the best speaker for this is Dr. Shekhar Chakravarti. Sir, may I welcome you on the dais to deliver this talk and enlighten us on this. Thank you very much.
Respected chairpersons, my dear colleagues, good evening to all of you. So, I have been interested to talk on a very important trial which has been published just 2 months back, and it has been published in the Diabetes Care. That is the GREAT trial. The GREAT trial means it is the glycemic reduction approach and how we can attain the targets. The main target of this trial is, you all know that the metformin is still considered as the first line drug in most of the situation. So what would be the second line drug? So we would like to discuss many things. So it compared the several classes of the glucose lowering agent in the type 2 diabetes. Already the patient is on metformin and the lifestyle modification. And this is basically the selecting the second drug, and more than 5,000 patients have been recruited. Usually the duration studied of 4.2 years of the durations, and HbA1c is 7.5% was average. And most of the patients are obese. You see Dr. Ghosh is nicely, outcome was basically to see the durability of the glycemic control, to see whether the defined HbA1c level can be kept below 7, assessed different types of medical outcome, different incidences of the side effect, and several psychological and the behavioral measures. This is basically a large long-term randomized study. This is one of the important landmark study because it invited and addressed so many questions. I'll try to address all these questions in a couple of minutes. Basically, the recruitment strategies was that most of the patients were in this trial. These are the demographic targets. All the centers are basically from the United States. About 20% was black, 18% Hispanic, and around 20% of the patients were supposed to with more than 60 years. These are all the centers, but the mind that these are not the community-based program or research. It is the research where the patients on the academic centers, veteran affairs medical centers, health maintenance organizations, and other organizations patients have been included. And primary recruitment was basically the electronic health record as a recruitment method was the principal one. Apart from that, physicians referral, mail, TV, radio ads, poster, brochure are the other parts. And these are the cohort where race, mostly the African American, white, Native Americans, Asian. You look at the Asian participation is very, very minimum of this trial. Ethnicity has been divided majorly between a Hispanic and the non-Hispanic. Male, female sex are almost equal, and age is usually have been recruited and divided into more than 60 years and the less than 60 years. Now the main results was after the 5-year study where it has been found that the retention was 90% and HbA1c as defined, but one important issue that you see on the trial, the HbA1c gradually rising and it has been addressed. 71% patient reached 77% or higher at the end of the observation. Maintenance was better with the glargine and liraglutide because the 4 agents have been taken. One is glargine, liraglutide, and glimepiride. And in comparison to the other, the liraglutide was associated with a lower risk of 16% and glargine is 13% lower risk for attaining the HbA1c of 7%. Because the endpoints were certain things like all-cause mortality, composite outcome of the glycemic control without weight gain and hypoglycemia, quality of the life, and depression or the diabetes distress. So some of the questions are very, very important. The first question which is, I would like to put the questions and how the GREAT trial has tried to address this and what is the implication in the Indian context. Say, Garvey et al. Tried the baseline clinical predictors of the durability of the glycemic control. It has been observed that the poor glycemic control was in the young population and those who have got a higher HbA1c. Higher HbA1c is acceptable, but one thing came out that the poor outcome is more in the younger age. So therefore, it is very important to address as an early. So better durability control in the older patients, more than 60 years of age, their HbA1c is better control, and no baseline features predict the treatment between differences. Confirmatory is findings that the better durability when the HbA1c not very high. Liraglutide and glargine are slightly more effective than glimepiride and sitagliptin. So take home message is, among all these 4 drugs, any drug can be taken as a second line, but early intervention is safe and effective even in the older patients. The main challenges is that all the centers are basically the US based, and where the Asian representation is very minimal. So therefore, the results of the GREAT trial, if we extrapolate in the Indian context, how much it is effective, this is questionable, but certainly there is role. And the ethnicity also, you see the ethnicity wise, the American ethnicity and the Indian subcontinent ethnicity is very different. And also the ages more than 60 years and less than 60 years population division is almost equal in the grade. But in India, you will see that the younger population is growing up, and the diabetes is appearing a decade earlier in the Indian subject. And if the Indian subjects, young people are poorly controlled, you can see you'll see the fate of the diabetes control in India. Next question is insulin sensitivity and the secretions are the predictors of the glycemic control. You'll find that the higher sensitivity, insulin sensitivity, and the greater C-peptide response predict the slower rate of glycemic control. Means those patients who are having the higher sensitivity is a better control. Now the insulin sensitivity was a stronger predictor for the sitagliptin, but not any other drugs. Now this is the comparison between the HbA1c control, C-peptide index, and the total C-peptide response. So what happens on the study, that the insulin sensitivity is improving in the first year, and after that the insulin sensitivity remains stable. And in contrast, that the beta cell response is gradually declining. So there are the difference in the beta cell response in the oral glucose among these 4 medications. And therefore, the inference is that the poor immediate response, and one important issue is in the first year of the trial, the sitagliptin doesn't show much improvement of the HbA1c. So poor immediate response of the sitagliptin when the sensitivity is low. Greater sensitivity and better secretion favor the glucose control, and all agents can be used as a second line therapy, but the early intervention is very important. For the first year, sitagliptin may not be that effective like other liraglutide or glimepiride or glargine. Now the challenges is that in this study, the average HbA1c was 7.5%. Whenever there is more than 7.5%, the rescue therapy has been implemented. But in India, the study has shown that the average HbA1c is around 7.5%, 8.56%, and the average fasting glucose is very high, average postprandial is very high. So in India, there is already suboptimal control. So therefore, if we want to actually implement in the Indian context, that this situation is quite tough in India. So reason for this not achieving the targets, you know, that the inertia is the most important thing, inertia from the patient's part, from the doctor's part. And this situation is not only in India, the US retrospective observation studies also shown that the inertia is a reality, and that's why the control is suboptimal. Now the third question is the effects of the treatment and sensitivity on secretion. You will find that the liraglutide improved secretion while the fasting and the oral blood glucose, both in fasting and postprandial sugar. Glimepiride improved the secretion while fasting. This is a sort of contradiction to our common belief that the glimepiride better controls the postprandial sugar, but the study shows that glimepiride improved secretion only while fasting, And the sitagliptin improved secretion only after the oral glucose. So confirmatory findings is the insulin sensitivity seems to be stable during treatment, and differing effects of the beta cell function suggest sitagliptin may be best suited to treating the postprandial hyperglycemia and glimepiride to the fasting hyperglycemia. So it is a contradiction to our common belief. So challenges is insulin sensitivity remains stable in the first year, but the beta cell function declines. So it suggests that the metformin in the early part and escalation of the metformin dose after first year may not be that effective when the sensitivity remains stable. Now coming to the all-cause mortality at the end point, you will find that this trial shows that the mortality is very low, around 3% mortality over the 5 years, and the mortality wise there is not much difference, but the liraglutide is probably better because it has got a good cardiovascular outcome. So more experience is required for the liraglutide too, but overall all drugs have got the same mortality. Now mortality rate is very low. You know that the cancer, the cardiovascular death is decreasing in the Western world, but the cancer death is still remain high. But in India, both the cancer and this cardiovascular mortality is more. So about the composite point, no baseline predictors for the treatment assigned. Glycemic control with the weight gain and hypoglycemia maintained better with the liraglutide. So conclusions is that limited lag by information importance of the. Now this the very important issue that for this composite outcome, the gastrointestinal side effect, which is around 30% with the liraglutide, has not been taken. Quality of the life, you will see that this quality of the health is a quality of the well-being self-administered, as well as the physical composite summary, as well as the mental composite summary. It has been shown that all these drugs are showing one important issue, that there was a hypothesis that the glargine may cause the reductions or decrease in the quality of life. It is not true. So improvement in the liraglutide in the first year is associated with the weight loss, and it has been shown that the first year the liraglutide is quality of the life. Those who are receiving liraglutide are better, but at the end of the 5 years the quality of the life almost same. So people with obesity may benefit of the liraglutide's effects on the weight. Challenges is injectable preparations, particularly liraglutide is showing, and glargine also showing the better quality of the life, but the cost of preparations of liraglutide and glargine is prohibited in India. Now coming to the depression, they have looked into the sitagliptin, liraglutide, glimepiride and glargine, what is the relationship with the emotional distress, and they have found that the depressive symptoms are reduced with the GREAT trial, as well as the diabetic distress, and interpersonal distress is also reduced. So improvement in the first year with the both liraglutide and glargine. It was a hypothesis that the glargine can cause a depression in the first year, but it has not been proved in this trial that glargine doesn't cause any depression. So no treatment worsened or distress in this trial. So contrary to the expectation, glargine did not warrant the distress. Also the diabetic distress and depressive symptoms and glycemic control over a period of the time, it has been observed that the glycemic control is irrespective of the depression. But the thing is that one important issue is that the adherence of the therapy with the medications is, see, when there is a depression or diabetic related distress, then adherence is reduced to medications. But reverse is not the true. If you maintain the proper adherence, depression or the diabetes related distress doesn't improve. So interference is the what I have mentioned. So for individuals with diabetes with a relatively short duration, emotional distress is associated with a lower medications. Non-adherence is a problem in India or no. The last question is the insulin as a rescue therapy. It has been, why the rescue therapy has been given? When the HbA1c is more than 7.5 in the trial, so insulin has been taken as a rescue therapy. In glargine, in glimepiride, liraglutide and sitagliptin, glargine was the rescue therapy. But in case of glargine, the aspart was the rescue therapy to control the HbA1c. And it has been shown that around more than 7.5%, those patients, around 35% participants required the rescue therapy. So advancing patients to the insulin treatment is challenging in this clinical trial. So therefore, glargine as an well accepted and continued as a second line therapy, as well as the glargine can be taken as a rescue therapy. Cardiovascular and renal outcome, it has been shown that the liraglutide is the most important to produce all sorts of MACE hospitalization for the heart failure, MACE 3, MACE 4, MACE 5 and MACE 6. So liraglutide is showing the cardiovascular benefit as a glucose lowering agent. Regarding this kidney outcome, almost all drugs are same regarding kidney outcome. So the limitations of this trial is that it has not taken the SGLT2 inhibitor, AGI and tirzepatide as a part of this study. So to conclude, GREAT study is considered as a landmark study because it addressed many unanswered questions related to pathophysiology and management of diabetes. It poses a lot of challenges where the results of the GREAT are extrapolated to the South Asian population, but it also ignited many questions which are still unexplored. So nevertheless, the GREAT study certainly can change the direction and quality of practice of the clinician who is treating diabetes. Thank you very much.
So, sir, very excellent presentation about the GREAT study, and as you have already pointed out that there are certain surprising outcome have come out of it. Now is open for the questions from the floor. Sir, would you consider glitazones were also not considered there, or
Glitazones?
PPR
No,
gamma?
glitazones are not included in the study. The glitazones, SGLT2 inhibitor, tirzepatide, AGI, they are not included in the study. So that's why this study has been started almost 2016 and ended in 2022. After that, all these publications, the first report came in 22 and the final report came in 2024. So at that time, that was it was very premature to take the SGLT2 inhibitor, and so therefore it is not a final study, but it is as a randomized multicentric trial.
Means still it probably a phase 1 study, and I mean to say another phase will come which will include the remaining drugs which are used currently. Okay, thank you very much.
Regarding the glargine, only glargine has been tried, or other insulins which are analogs and the pickless?
No, only glargine has been
taken.
Only glargine has been taken.
So glycemic reduction, it's there, but glargine has also other competitors who are equally effective. But in this study, they have taken glargine only.
Yes. Yeah. Glargine has been taken as a representative of a basal insulin. So because you see that all the studies, guidelines suggest that whenever there is a requirement, you start with a basal insulin first. But so that's why glargine has been taken.
Yeah, main focus is on GLP-1. Men addition, they suggest for initiation.
In certain areas, the GLP-1 RA is important, like liraglutide. But as a second line therapy, effectivity, all the drugs are same, oral and as well as the injectables. But if you really see the cardiovascular outcome, then liraglutide, reductions of the body weight, liraglutide is certainly better. And the important issues has been identified is that after the sensitivity remains stable, then if you use the drug which improves the sensitivity, it is not effective. You know that the metformin is the insulin sensitizer. Yeah. So after the first year, the sensitivity remains stable. After that, the sensitivity is not improving. So if you escalate the dose after the first year, say you double the dose or increase the dose, you will not get any incremental effect of the sensitivity.
So you have to add other drugs.
Or any other drugs, which includes like pioglitazone, any other drugs which can improve the sensitivity. But simultaneously, the beta cell secretion falls gradually. So those drugs which works by stimulating the beta cell, like glimepiride, like GLP-1 RA, like other drugs. So in those cases, you will find that you can use so therefore metformin certainly will be there, but metformin will be ineffective after the first year. After that, a second drug is certainly required. After the first year metformin. Maximum metformin can provide into first year.
So we have to go beyond metformin. That's
yes, you have to go beyond metformin.
Nice talk. Nice talk.
Okay. So, thank you very much, sir. Now, moving to the last talk of today's session, the last talk before the dinner also. And for that, I request Dr. Rajiv Kovil to talk on the link of diabetes and cancer. Dr. Rajiv Kovil is a consultant diabetologist at Kovil Center. Okay, sir. And he has presided over many organizations, the lectures he has delivered, and awards and publications. Over to sir.
Thank you so much. Thank you, Dr. Patni. Let's not have backbenchers. Whoever is behind can come ahead so that we have more people at eye contact. Dr. Bhavatarini, you can come ahead. So I'm going to individually call people ahead. It's the last session. A lot of data in the last 1.5 decades made diabetologists, endocrinologists into cardiologists, nephrologists, technologists. And I think with the era which is going on, we'll also become oncologists in some time, because that's what we are seeing. This is the flow of my agenda. I'm going to just prick your mind on this, because that's what we are going to get. This is what, so we have enough people with diabetes, but we have enough people also with cancer, and it has just gone up in the last 3 decades. And the co-occurrence of this problem is very high. And somebody would have asked me that why are we giving a talk on diabetes and cancer, and is it relevant? Because the co-occurrence is high, and some smart man almost a century back had suggested that probably both these diseases will cause deaths in our country. And if you look at what is the prediction of NCDs by 2040, 75% of deaths are related to cancer, diabetes and heart disease. So gone are the days where infections will take people away. And the risk of cancer goes from less than 1/10 to almost 1/6. And the cancer deaths have doubled since 1990. We can say that urbanization, tobacco, alcohol abuse have all caused that. But if you look at what are the specific cancers that we see in people with diabetes, you'll be surprised to see breast cancer there, pancreatic cancer, which we are aware of, 1.8 is the OR, bladder cancer, colorectal, endometrial, and surprisingly chest as well as prostate cancer is lower, even renal cell carcinoma is lower. Prostate, the hypothesis is that most people with diabetes and hyperinsulinemia and obesity have late onset hypogonadism and lower testosterone as they grow older. So probably that's the reason prostate cancer is lower in people with diabetes. But mortality from cancer and cardiovascular disease is almost reaching similar proportions across the globe. And whether we know that the metabolic abnormalities in obesity and diabetes drives cardiovascular disease, but those metabolic abnormalities is also driving colorectal, breast, endometrial and pancreatic cancer, and especially where you have endometrial kind of cancers, because insulin seems to be there as a primary driver. This we know that insulin resistance can cause all these, and insulin resistance and hyperinsulinemia and some part of our diabetes therapy, which I will allude to in some slides. But what is very, very common is that you have a reduction in the IGF binding protein because of hyperinsulinemia, and hence you have increased IGF-1. This is one of the pathophysiologies in breast cancer, because breast cancer cells have been found to have increased in insulin receptors and increased IGF-1. Data to suggest that people who have higher IGF-1 as compared to lesser IGF-1 have higher chances of breast cancer, and especially estrogen positive or estrogen receptor positive. Now we know that hormone related modulation is happening. So there are a lot of association of diabetes and cancer, and you'll see that endometrial, breast, liver, pancreatic and colorectal, the odds ratios are pretty high. Role of hyperinsulinemia, hyperglycemia, dyslipidemia, the role of adipokines, IGF-1. We know that insulin also is a growth promoting factor. It can stimulate certain IGF-1 factors. Some part of our therapy can also be there. What we need to understand that endogenous insulin is actually captured by the liver, and we have very little in the periphery. But exogenous insulin, very little is captured by the liver, and as it is in type 1 diabetes. So there's hypoinsulinemia in the liver. That's why a few years back, there were studies being done. There were products which were hepatospecific insulin and peripheral specific insulin. But the peripheral tissues actually receive more insulin during a hyperinsulinemia stage, and also when a patient is on exogenous insulin. And that seems to be a factor which is considered as a promoter for all kinds of cancers as such. So peripheral tissue hyperinsulinemia and liver hypoinsulinemia seen in people with type 1 diabetes, obviously because of exogenous insulin, and in type 2 diabetes, chronic liver hyperinsulinemia because of the underlying pathophysiological defect. And as I said, that many cancer cells, especially breast cancer, there is an increased insulin receptor content, breast, lung and colon, and that seems to be the reason because we are seeing much more incidence of cancer in people with diabetes. If you look at what are the risk factors, not getting into there, but these are the risk factors for cancer and also the risk factors for obesity. They seem to have a common soil hypothesis, and that's why there is a lot of grays together that they cause. Anti-diabetic medications, metformin is the only one which seems to be safe when it comes to cancer. If you look at malignancies, and if one remembers 1.5 decades back, there were reports of analogues, and especially glargine, whether it was the Swedish study, the German study, or the British study, they all had shown that glargine and cancer incidence, but they were observational studies, and there can be some truth in that, because as an analog it seems to be more has more potential to stimulate the IGF-1 as compared to pure insulin that we give. But insulin as such and the dose of insulin has been incriminated in cancer. Origin study, which was done in pre-diabetes and diabetes, as such a randomized control study, did not show. It was a cardiovascular outcome study before cardiovascular outcome study was mandated. No increase in cancer was seen with glargine. If you look at OADs, the insulin sensitizers, whether it's metformin and TZDs, seem to have some benefit. Probably it's also related to the AMP kinase activity of metformin, which acts only on the liver. It reduces the adipocytosis. And probably metformin is one drug which can reduce and there is a lot of RCTs going on right now also, especially in the elderly age groups, in improving the lifespan with metformin, and probably it would be a repurposed drug. We know metformin is used in tuberculosis, in rheumatoid arthritis, in polycystic ovarian disease, and probably would be used in prevention of cancer in future maybe. TZDs have a dual side to it, because Rosie had shown that it was a lower risk of cancer with Rosie, and this is a meta-analysis of randomized controlled trials, almost 80 trials, and we know the story about pioglitazone and bladder cancer. The jury is still open on that, whether pioglitazone causes bladder cancer or not, but bladder cancer is higher in people with diabetes as compared with people without diabetes. Incretin-based therapies, we know that The medullary cancer of the thyroid has been seen in rodents with all kinds of GLP-1 therapies, but there is no human study which has actually pinpointed a cause and effect of any GLP-1 and medullary thyroid cancer. But in spite of that, there is a package insert and black box that if you have a family history of thyroid cancer, do not use GLP-1. Again, we have always thought that this is a cobweb in the mind, but ESD, ADA came up with a joint statement 2015 that incretin-based therapy is not linked to pancreatic cancer. And a lot of cardiovascular outcome trials have actually evaluated pancreatitis and pancreatic cancer, but we've not had a very clear-cut association. Some association of a pancreatic ductal proliferation, ductal metaplasia, some pancreatitis numerically higher, but not significantly higher. SGLT2 inhibitors, if you go back, DAPA in its phase 2 study had shown some signal towards bladder cancer, but we now know that with the robustness of evidence which DAPA has in cardiovascular outcome and chronic kidney outcome, we have not come across bladder cancer which was seen as a phase 2 marker in this. So if you look at diabetes medications, metformin seems to be safe. There is a debate between Rosie and Pio. SGLT2 seems to be safe. GLP-1s and all incretin dose therapies have not shown cancers in humans. Insulins, the higher the dose, the exogenous insulin, the risk of cancer numerically is going up. Who should be screened? Again, we don't know who should be screened. But unexplained weight loss, multiple risk factors we should screen, and there is no guidelines on screening, but it's 20 to 25% higher in people with diabetes as compared to people without diabetes. Not getting into details of management, but take-home points is diabetes is associated with increased risk of liver, pancreas, colon, rectum, breast and bladder cancer. Is associated with a reduced risk of prostate cancer. It could be related to shared risk factors. Possible mechanisms could be the mechanisms which drives diabetes and hyperinsulinemia, hyperglycemia and inflammation. A healthy lifestyle seems to help. Specific anti-diabetic medications, cancer risk is limited. Observed associations have been found. Cancer risk should not be a major factor in choosing any anti-diabetic medicines. Early evidence suggests that metformin is associated with a lower risk of cancer. Insulin might be associated with increased cancer risk, especially when the doses are higher. People with diabetes should be strongly recommended to undergo age and sex appropriate cancer screening. Secondly, pancreatic cancer, a word of caution, newly diagnosed elderly people with pancreatic or type 3C diabetes often have association of pancreatic cancer. So sometimes it's a reverse causality that the patient may actually present with diabetes and may be harboring a pancreatic cancer. So risk of cancer in diabetes goes up. A series of studies and meta-analysis confirm that there is risk of several solid and hematological malignancies higher. Chronic hyperinsulinemia, both endogenous and exogenous, could be factors, and some suggestion of some anti-diabetic drugs maybe have some influence. Thank you all for a patient here.
Thank you, Rajiv. As usual, a very huge topic covered very beautifully in a very crisp format.
Thank you, Alok.
And you covered it before time, and you did a fantastic job. Thank you, Rajiv. Thanks for a very lovely presentation.
So thank you, dear. Thank you.
Especially the carrier messages were very clinically relevant. So thank you.
Okay, loud round of applause for Dr. Rajiv Kovel. Very interesting. Long way to go in this topic. We can close the session now.
Thank you.
Thank you so much.
Thank you so much.